Welcome. Wishing everyone a very good morning, afternoon, depending where you're joining from. Once again, I would like to welcome you into this room and wish everyone a great session. I am Lais Junqueira, Quality, Patient Safety, and Innovation Manager at Elsevier, and today I have the honor and the pleasure to be sharing a space in your screen with Dr. Farina Salleh, Director of Quality and Consultant Emergency Physician at the National Heart Institute in Malaysia. Thank you so much, Dr. Farina, for joining us, joining this conversation and sharing your thoughts and experiences with us.
Thank you, Lais, and thank you, Elsevier, for this kind invitation. And let's hope we have a fruitful one this evening. And we hope that the information will be useful for everyone. If not, it will be some sort of experience sharing session.
Thank you so much. And before we begin, I would also like to invite our audience to participate in the discussion that Dr. Farina and I will have today. So I see the chat is very active already. If you have any questions, if you have any comments, you can send them via the chat and also via the Q&A button that you have on your screen. We will do our best to include you in the conversation as we are doing the webinar, but we also have a dedicated session for questions and answers by the end of this webinar. So thank you very much in advance for sharing your inputs and your questions as well. So before we start, just to set the scene of the conversation that's going to happen, I have aggregated some statistics regarding the burden of unsafe care available in the World Health Organization Patient Safety Action Plan for 2021-2030, the recent publication that I believe most of us have read already. And the numbers that you see on your screen, they reflect what we see on our day-to-day lives as patients and as clinicians in healthcare today. We have that in high-income countries, 1 in 10 patients might be subject to an adverse event while receiving hospital care. In low and middle-income countries, the figures are even worse. They can be up 1 in 4 patients suffering harm. And the statistics are that we have 134 million adverse events occurring annually that lead to 2.6 million deaths. And these numbers also have a very significant financial impact. In high-income countries, up to 15% of hospital expenditure is due to safety failures. A recent analysis exposed that the social cost of patient harm can be valued to $1 or $2 trillion a year, and that eliminating harm could boost global economic growth by 0.7% annually. This is greater than the GDP of many countries. Now, all these figures, they paint a very concerning and very urgent scenario, right? Very alarming. And even though sometimes we get caught on those very alarming figures, many times we do analyze them from a distance, right? So I would like to invite you to come a little closer to those numbers and try out an exercise with me. And to do that exercise, all you need is to type your answer on the chat. So let's see how that goes. We know that the WHO estimates that there are 421 million hospitalizations per year in the world. And that we also have 42 million adverse events on those hospitalizations. If we take a very, very, very conservative approach and consider that only half of those adverse events are preventable, even though literature suggests that up to 80% can be preventable, we would come to a 21 million figure for preventable adverse events. Now, I would like to ask you to type on the chat the number that you would consider acceptable for preventable adverse events, considering the statistics that we have nowadays. So you can send your answers on the chat. Just type a number and let's see what the audience thinks about it. I see some numbers coming up. We have 10%, we have 0, we have less than 10 patients, 10%, 0, less than 10%, 5%, another 5%. So we are in between 0 and 10%. I can see that here on the chat, less than 8%. So now let's do the second part of this exercise. And I want you to think about your family and close friends. So, and people that you saw that you like on the last 6 months, everyone that you saw. If that's the sample, and if they were the ones being hospitalized, what would be the acceptable number of preventable adverse events for you? I see some more zeros coming up. 0, 0, 0, 0, 0, 0. Safe to say that we all say that it's 0. So we have many zeros coming up right now. So that's precisely why I do the exercise, right? The purpose of the exercise is just to remind us that when we talk about patient safety numbers, we're talking about people, right? People with families, loved ones that live in our society. And that's why when we talk about quality improvement, there's one sentence that I love, and I always say that if you are in healthcare, you should be in quality improvement and patient safety. However, this movement towards a quality improvement and patient safety mindset isn't one to be taken for granted. Quality improvement and patient safety are not traditionally taught at health school as part of the curriculum with assigned subjects, for example, which makes it even further complicated to engage professionals in such activities. So I would like to invite now Dr. Farina to share with us how this translates in her experience as a clinician and a quality director. So Dr. Farina, I just mentioned that quality improvement and patient safety aren't subjects traditionally taught at medical school. How does that gap impact the development and implementation, for example, of a quality improvement program and practices in a hospital?
Yeah, thanks for that, Lais. And I'm happy to see the response from the participants, where, you know, if it does involve someone that you know, and more importantly, people that you love, that, you know, safety events are not tolerable. You know, you can't tolerate these because some may have very dire outcomes. So just to move on from that, I don't know about anyone else who's in this webinar, but definitely when I was a medical student, this was not touched on formally in my medical school. And I'm embarrassed to say it's been a while. And even in the postgraduate studies, there is, again, not even much of an introduction to it. And as a clinician, I think the first time I was really exposed is when you start to come out as a specialist after your postgraduate studies, and you're given a bit of administrative responsibility, and then you get involved with accreditation. So I think this is the first introduction, if I can say just for me. And this is why I believe that it's a difficult concept for a clinician. And when I joined IJM, they actually had a consultant, you know, guiding us through a certain accreditation. And I just could not, I thought I was not clever. You know, I really thought there's something wrong with me because I couldn't get it. And I was frustrated and somewhat angry with myself because I was like, you know, you're a clinician, you're a specialist. You can't even understand what this person is trying to impart, right? And it was very frustrating at the beginning. I didn't know what impact it had on me or the people or the patients that I treated. I thought, you know, when they talked about looking at quality indicators and measuring data, I thought it was something that was just a burden on the already busy clinician. I could not get what's in it for me, what's in it for my patients, you know. And it took a while. So I was one of those who was very not to say reluctant, but I had a bit of anger, I had a bit of frustration. I had a difficult time accepting what this concept was. I didn't know the why, and I think in a lot of cases, this is what I try to teach people nowadays when they have difficulty trying to understand this quality and patient safety. Is that the why? What is the why for this? And what changed my perception is actually looking at outcomes. Good outcomes may change your perception, and bad outcomes may change your perception as well. And it might be, one might be more impactful than the other. I always, once I understood it, I always tell people that it is hand in hand with your clinical management. It's something that occurs in the background. There are people working on this, and from the people ensuring that your OT equipments are cleaned properly, stored properly, to your drapes, being cleaned to a certain standard. All this happens in the background that the doctor may not be aware of, but it's happening, and it's a very important part of you delivering that care to that patient. So yes, as Lais mentioned, if you're in healthcare, you are already in quality improvement actually, right? How can you not agree, right? And this is part of you giving this holistic care to patients. And it's about everyone working together, everyone finding out what are the challenges and trying to reach solutions and trying to give better care, and learning about how to measure quality. And, if you measure it, you can show improvement to it. And this is what we call, evidence for you to continue this good work. So to me, that's sort of an introduction to how I got involved with quality and patient safety, and how I would advocate it to others. More of, this is just hand in hand, something that one cannot be without the other, if you may, Lais.
Absolutely. I couldn't have said it better. And I completely agree with you. Now, would you share with us an example of a quality improvement project, or a situation where you had to engage with your clinicians and that you could actually improve by inserting them into the quality and patient safety, let's say, zone?
So I think just based on my own experience, as I mentioned, it's simply understanding why. And this principle I learned sometime in medical school, and it had nothing to do with medicine, by the way. I think it was something else. And it's called the principle called what's in it for me, or WIIFM. So you have to, when you communicate to your colleagues, especially clinicians, they need to know what's in it for them, and the way you present information, or you want them to do something involved with quality, they need to know what's in it for them. If you show them a graph of an improvement, they will be in it, and to involve them from the start, and to get their opinion on the issues, and also in the process of those improvements, I think is also very important. It's very hard because, as you know, clinicians are busy, and they're focused on giving the right medicine to the patient and the right treatment. But at the back end of that, when you help with this process, you are not helping one patient, you're helping all the patients, and so everyone. So again, I would put it to them this way, so that there's some buy-in and because you definitely cannot make these improvements on your own. A quality management department cannot do it on their own. It has to be a team process. Yeah, I have some examples, but maybe I'll chime in later.
Sure thing. So one thing that you mentioned, and one thing that we always talk about when we talk about quality improvement, is the need for a systems approach, right? We need to make sure that there is a system going on that, let's say, safeguard patients. And when we talk about systems approach to improvement, traditionally, we are talking about a system as a set of processes. Now, in healthcare, a very important component of a safe system is also decision-making. So from a clinician perspective and also from a leadership perspective. And what would you say are the key components of a safe decision-making system?
Okay. All right, if you're a clinician, right, we already know that research is going all around the world on various topics and medicines and treatments. And this is what we call, you look at the evidence and then you reach a consensus and then you develop guidelines or protocols. And this is what a clinician follows. Okay, this is how I want to treat a heart attack. This is how I want to treat heart failure, right? And there's specific guidelines and specific flow charts for that. So actually, when you talk about systems and processes, it's kind of the same, you know, we talk about evidence-based and evidence-based for you to make decisions for your systems and processes and data-driven decision-making. And maybe at this point, I think, Lais, can we go to the next slide? I just want to show you an example. Okay, so this is something, sort of a core business, if I may. This is our door-to-bloom time for primary percutaneous coronary intervention for STEMI patients in the National Heart Institute in Malaysia. And of course, this is something that involves multiple departments and may also involve inter-hospital relationships, yeah? So obviously, the shorter the time to the treatment, the better, right? So we see here, starting in 2009, the door-to-bloom time is about 80 minutes, all right? And you can see a dip there somewhere in 2014 and 2015. And I showed this earlier to Lais, and she said, I'd like to know what happened there. And actually, it was just a process improvement. And it started with a hospital nearby where we wanted a cleaner process. So this is not about how early you give aspirin, how early you give antiplatelet to the patient. This is actually a time-based intervention that the patient needs. And so because of this collaboration between two hospitals, this is actually the General Hospital Kuala Lumpur next door, and there's a referral process, the emergency physician in the other hospital will call our cardiology registrar, who will call the cardiology consultant, make a decision, it comes back down, it goes back there. And there's time wasted in these processes. There's time wasted in trying to transfer information and making decisions. So we cut all that out. We cut out a lot of other things, such as doing an ECG once again or doing blood taking again. And this is the results. And wondrously, this process improvement is actually expanded to other patients and not just this hospital. And you can see this result. Just go on to the next slide, Lais. And the next slide is actually on outcomes. So the top blue color is actually the percentage of these STEMI patients who receive primary PCI within 90 minutes. And the bottom is a mortality. So you can see these two lines spreading apart, right? So more patients are getting the treatment on time and less patients are dying. So, you cannot fight with data, this is not made up. And might I add that within 2014 to 2017, previously we have maybe 80 cases a year, we were up to 350 cases a year. And if you look at 2020 and 2021, we were hit with COVID with added processes to consider for the safety of patients, and we still maintain this, and it's always a learning process. All right, perhaps I can go to the next slide, and I'd like to tie this in with COVID actually. Yeah? So there are various ways of collecting data in a hospital. You can look at patient safety events. You can look at quality indicators. What we have in the National Heart Institute is actually this dashboard. Yeah, I had to cover it a bit, and if you can see on the left, it's actually mostly IPSG, or International Patient Safety Goals. And right from the just one look at this, and okay, there are some things where you struggle throughout the year. See the ones in red throughout the year, and there are some that just pop up right in the middle, right? So you have a bit of red in the middle, and you're wondering, hey, we've been doing well all this while. What happened right here? What happened during these months? And I just wanted to use this as an example. And this is regarding patient falls. And what happened in those months between April and June and July was that we had a whole outbreak of COVID in the country. And, this infectivity was very high. And because of this, we said, absolutely no one is to accompany the patient. And this is the outcome. So something's got to give, and this is a good way of monitoring what's going on in your hospital, because when something special occurs or there's something that's out of the ordinary, you will have some result like this and you need to take action. This is unacceptable. As you all mentioned, if this happened to someone you love, this is unacceptable, yeah? So as you can see, we took very hard measures to bring this number back down. Yeah, so someone says the red spots are an eye-opener. Definitely, right? It pops up at you. Lais, do you want to add anything at this point?
Yes, I think it's very, very interesting how you're sharing, and the key point for me that I'm hearing from you is how important it is to connect the people to the why, and also make sure that we show the data so they can understand the why. It's not just an abstract or subject thing that we're talking about, we need to improve. It's really the data that shows us and that drives not only that initial engagement, but also once we're in the process, how can we improve the process? And how can we make sure that we keep on making the better decisions, the safer decisions for the patients from a clinical side, as you mentioned, but also, of course, from a management side. Do we need to change the flows? Do we need to connect with other institutions? So I think that's really valuable. I see on the chat here, I'm just going to bring up the chat a little bit, that we have here in Monash University, patient safety modules are taught in year 5. So that is fantastic to hear. What Dr. Farina and I were discussing, and we talked to some colleagues around the world, that unfortunately isn't the reality yet. So clinicians do join hospitals and they start their careers, and then they start seeing quality improvement and patient safety not as allies or the fundamentals, I would say, but I'm a little bit biased as a quality and safety manager, but as fundamentals of care. However, it's very, so what happens is institutions then have the need to start teaching them and to start engaging them into this, and data can be a great ally, which is what I'm hearing from you.
I love that. Data can be a great ally, but you have to present your data in a way that everyone understands in an easy manner. It's not complicated. This is just one more example. This is code blue versus code purple. And actually code blue is just, a patient who collapses in the hospital, and there is a team of resuscitation experts who will be on hand. And these are advanced cardiac life support trained personnel, including an anesthetist or cardiologist and nurses from the intensive care unit. And we've had that for many years, and we've monitored this for many years. However, when this is an example with to do with COVID. During the COVID outbreak, we had to have something called the code purple, which means protected code blue. And there are extra processes such as an anesthetist who is going to intubate the patient will put on this personalized airway protective equipment, which does take time. And initially what we saw between the two was that the response time was delayed in the code purple. And I have to thank my medical director, because he noticed this and he was like, first of all, he asked for the data. And then when he noticed the difference, he was, he asked to be updated every month. And what the hospital did was that we looked at the outcomes. If you can see, achieved ROSC, that's 73% in the code blue and 44% in code purple. And survival to discharge is 49% in code blue and 22% in code purple. So that's almost half, right? And granted that we do this code purple for suspected or confirmed COVID patients. And because of these processes, it leads to delay, and obviously the outcome is poorer. So what do you do with this data? So what we did was that, look, everyone needs to be trained in this. And so we ramped up the training in code purple so that everyone is aware, and there's a standardized method. in this team dynamic, so that we wanted to improve the outcome. So I may get back to this, after a year and see whether there's any improvements. And we started off concentrating on wards handling positive COVID patients. So again, this is just a way of presenting data that is simple, to me, meaningful. Your solutions may not be grandiose. It may not need to involve a lot of monetary involvement. It could be as simple as going down to people and disseminating information, standardized information. And, we hope for a better outcome when we come back to the study, maybe a few months from now. So this is another example.
Thank you. Thank you very much, Dr. Farina. I'm going to ask a question now to the audience, and you can type your answers on the chat. How do you, if you're a clinician, how does the data from the hospital get to you? And if you are a quality manager or someone responsible for sharing the data, how do you usually share the data with your clinicians? And you can type the answers on the chat right here. As I ask Dr. Farina the next question. So we know that the pandemic has brought to light many opportunities to use technology as well to enhance our abilities, for example, to trace infections, to reach patients, to make better decisions regarding evidence-based content, and many other applications that we saw in the day-to-day life, especially during the pandemic. In many countries, technology is being used, for example, to deliver safe information for patients and clinicians, and also to nudge towards a safer behavior, for example. How do you see the role of technology in patient safety, and which were the challenges that emerged as technology was being implemented?
Okay. So could you go to the next slide?
Sure.
All right, so I just wanted to show this just briefly. A few of the tech used in the National Heart Institute. The IGN surveillance was actually for the staff to key in their daily record. Below that, if you can see me trying to record my temperature, I'm not a very tall person, so you can't see my face. And, we record our temperature, and we also declare our health status. You can also add your COVID test results, or whether you are a person under surveillance, maybe an exposure from outside. So this is a declaration that we do every day. And we've moved on from that temperature screening being our punch-in, our attendance to work. The IGN tracker, this is just, the simple QR code. And in the end, you can actually look at your journey history, and this is used for contact tracing. We also recently developed the IGN Company. So this is for accompanying persons accompanying patients either to the clinics or caregivers in the ward, for them to also declare themselves, and also for us to monitor who is accompanying the patient. Let's say, for example, you have an appointment at the clinic. I know that you're coming in. And if you associate yourself and put your details with the patient's details, then I know that you are accompanying this patient who does have an appointment today. This also limits the number of people coming into our hospital. And the last one there that I wanted to show is the IGN COVAC. IGN was the one of the vaccine centers. Actually, we concluded today after 27,000 doses. And this is for patients and also staff and referrals, and we've also done teenagers, yeah? And what we did was this system which helps in enrollment, helps to give you a real-time data on who has come, who has been injected, how many are left, who has been dropped. It's involved in generating a consent form. And, so we don't have a huge IT department. This is all in-house. And I'm sure other hospitals, have these some sort of expertise in their hospital. If not, it's worthwhile to invest to have in-house developments of this technology. In terms of challenges, so I think Lais asked me before whether we use this in clinical management. So here are the challenges. We go strictly by the Ministry of Health guidelines on management of COVID patients. And these are given to us via email, disseminated to all the hospitals. Sometimes we have online education from infectious disease experts and, in training us in how to manage our COVID patients. Obviously, it came to a point where, there's not enough infectious disease doctors to manage all the patients that were positive. And, the government has been quite responsive in helping the hospitals, whether public or private, help to manage these hospitals. At some point, we had a referral process where it was centralized and we gave information regarding our positive patients, and the patients were sent to the designated hospitals. So again, there's a bit of technology there. However, because the guidelines do change because of evidence and updated clinical guidelines, it was a bit difficult to put in clinical guidelines into technology. So for us, it's still a bit manual, but again, we use technology to disseminate information.
That's very good. And I would like, I see some audience members are already replying to the question that we made on how do they share quality improvement data, right? And I think that also relates very much to this slide that you have right here, which is show me the data. So I see there are different questions here. So the first comment is from Jason Sukiya. In his institution, I share through monthly hospital conferences and annual research forums. So that's very interesting as well. There is a very good comment here. Hi, I'm an emergency physician. Where I used to work, we're still using papers. It's a challenge to design an A4 sheet full of meaningful data that can only be used to monitor quality. Compliance to fill up the form is an issue. An automatic response is another issue, but persistent education on the importance of those data for the staff is one of the keys. The analysis of this data usually done by clinicians and shared to the quality unit officers when needed, and vice versa. Usually there will be a liaison officer between the clinical counterpart and the quality unit. Dr. Farina, does that reflect also the work that you do in your hospital? How do you see this? And do you also relate to some of the challenges that were posed by this comment?
Yeah, and we're still partly paper, although I've shown you those bits of data collection using the app. And this slide is actually what was generated from the IGN surveillance, as I mentioned earlier. And, this is showing compliance to self-declaration. I wanted to mention that we have this concept of my IGN, my responsibility. So again, it's your responsibility as the medical staff to declare whether you are healthy to be coming to work. And the top graph is actually data in May, and the bottom one is in more recent months, September. And if you're one of those departments that are below the line, which is one of it is mine, you'd stick out like a sore thumb, and you'd want to, disseminate information to your staff even more efficiently, And this show me the data. This is my my medical director. He's a data person. You can show him data, and he can make a conclusion. And so yes, so what this person says, collecting meaningful data, analyzing it, making it simple for everyone to understand, whether it's a clinician or anyone in the hospital. It has to resonate with everyone, and don't be intimidated by clinicians. We don't need high-level data when it comes to processes. You're not analyzing a drug or medication for treatment. We're analyzing a process. We're analyzing the outcomes and the safety. So yes, we do use paper, but make sure what you're collecting, as you said, is meaningful. It's not taxing. It's the minimum required for you to make a meaning out of it. Don't go crazy collecting data and then not analyzing it well, or not doing anything. That's the worst bit, not doing anything with something that you're collecting crazily, too much details, yeah? So that you have to put in a lot of thought into what you're collecting.
Thank you. Thank you so much, Dr. Farina. And I see there are more comments coming up here on the chat. I would like to first, thank you very much, Dr. Farina, for sharing all this knowledge, all this experience. I think during one of the calls that we had before this webinar, you mentioned that professionals are working a lot now, and especially with the crisis, and they are advancing a lot, but opportunities and the time to share those findings and all the activities and the opportunities for improvement can be very tough. So I would like to once again thank you so much for your generosity in sharing your experience with us, of course, as well as giving us insights and really making sure that we need to show the data. I think if there's one thing that we can take out of the one message that to take out from this webinar is show the data and engage people in the system, right? And that was one element that kept coming back throughout the conversation, which was the need to build that system that provides safety, right? And I really like this quote by James Reason that we have all read before, that we can't change the human condition, but we can change the conditions under which humans work. In other words, it's really how can we create a system that makes sure that people are celebrated and that they are doing their best with the data supporting them, if I can summarize in a couple of words. And that safe system contains not only the processes, but also the decision-making. And that a key component of that decision-making is data and information as well. So as we mentioned before during this conversation, we traditionally look at safe systems as a set of processes, right, in healthcare. But we do have a further complicator, if I may call it a complicator in healthcare, which is the need to always make safe decision-making, which makes the industry require a robust approach to make sure that the people are supported to make those safe decisions. And part of this is the emphasis on the conditions under which people succeed, which is what you mentioned right at the start of our conversation. How can we show them that if they follow the protocols or if they do start working on improvement, they will succeed? So how can we make sure that the data shows that, and not only the data that shows when people fail? And to be able to do that, we need to connect the people, the process, knowledge, and also technology can be a great ally, as you just showed with the COVID examples in the hospital. And a key element that we can never remove when we're talking about healthcare is evidence-based practice, right? Just a quick reminder, evidence-based practice is not only about the evidence. Of course, we have the patient values and clinical expertise as well. It's this triad of the combination of patient values, the clinical expertise, but of course, the best research evidence that we have available. And when we're talking about scientific evidence, there are a couple of challenges that we face, right? We know that there's an estimate that the doubling time of medical knowledge was estimated at 73 days in 2020, which means that every 73 days, medical knowledge would double in size. How do we keep up with that? And another very interesting data that's more about COVID is there's the WHO database. And I recently checked it again, and we see that there are 308,000 articles indexed there. So quick calculation, if someone was to read 20 articles a day, completely not feasible, but if someone would read 20 articles a day nonstop, it would take them 42 years to finish reading. And by the time they finished reading the articles that were published 42 years ago, I would say much would have changed, right? And just to give us an idea of what does 42 years mean, when we look into 42 years ago, this is what was being created in our society. We were listening to music on Sony Walkmans. We were accessing our data in a Mac computer, Apple III, and omeprazole was first being patented. So that was how our society looked 42 years ago. Can we give ourselves the luxury of 42 years to be updated, to have the most current information? I would say no. right? And I'm sure Dr. Farina, as an emergency physician as well, 42 years, that's a long time to be updated, right?
Quite impossible.
It's quite impossible, exactly. So how can we support this? Well, that's exactly what we do here at Elsevier. We support people making safer decisions by providing access to current, credible, and evidence-based information. So what we do is basically giving people access to knowledge that is powered by technology. And there are different ways that we do that. So I'm just showing you a very brief overview of the different platform solutions that range from reference solutions, as you can see at the beginning of the solution wheel, and also clinical practice, learning and competency management, patient engagement, and clinical pathways. Now, how does that reflect the challenges, the journey that we have been discussing during this webinar? And I would like to share with you the quality and patient safety journey, which is what you see on your screen right now. This journey was developed in partnership with the Brazilian Patient Safety Society, Quality of Care and Patient Safety Society, and is now used nationally as a North Star to actions in terms of patient safety and also quality improvement. As you can see here, the pillars, they address the essentials to create and maintain a safer system for patients, starting at community engagement and health literacy. Dr. Farina briefly mentioned that topic when we were talking about technology and, for example, contact tracing, and how do we make sure that the community is also involved, right? So we have the community engagement and health literacy, information management. I think that was the main portion of the webinar. We were talking about how do we make sure that information is managed, that data is managed so it can become information and be shared with clinicians to compose their knowledge base. We also have a very key component of staff education and skills. So making sure that staff are empowered and that they have the right tools to increase their knowledge, to enhance their knowledge, and of course, enhance their skills as well. One thing that I heard once during a patient safety conference that I never forgot was no clinician goes into medical school, nursing school to cause harm to patients. So that's a given. Nobody wants that. But how can we support them to actually have that safe care, to provide that safe care to patients in a scenario that is not only complicated, but very complex, with many different factors playing. And as we saw at the beginning of this session, the results are reach patients, they reach people. So it's a very risk-prone industry, and how can we make sure that we're supporting the people with processes, with technology, with knowledge, so they can be their best. Then after staff education and skills, of course, there's a very important component, which is care of patients, practice, the day-to-day practice, right? How can we support clinicians making better decisions and to have the processes that enable them to practice safely? A very important component of that is also patient participation. And during COVID, I think that was even more highlighted. For example, for when we had patients not being able to communicate with their family members and patients were by themselves, let's say like that, at hospitals, how can we make sure that they are part of the equation, that the families are part of the equation when we're doing decision-making as well? So it's not only about education, but really how to engage, how to participate. And of course, by the end of this journey, which is not the end, sometimes it's just the beginning, is research and continuous improvement. How do we learn from everything that happened and we circle back in a virtuous cycle of continuous improvement? So today, I would like to invite you to take a closer look at 3 pillars, as you can see on the screen: staff education and skills, care of patients, and patient participation. And now I will show you in a couple of minutes, so it's a very high level overview, how knowledge and technology can support those clinicians making safer decisions and also learning and enhancing their knowledge. So I just want to show you some examples. So the first example that you see on your screen is staff education and skills. I know many of you here in this call today already know the Clinical Key Suite, but if you don't, I would like you to imagine a scenario where you're able to access a website, an online tool that provides current, credible, and evidence-based content that comes from trustworthy sources. Now, this content ranges from books to drug monographs, calculators, clinical practice guidelines, clinical overviews, drug reports, and there's also a section that's dedicated to patient education. That's what Clinical Key Suite offers. It's a very easy navigation, and clinicians can search and browse content and use the filters. And here comes the very important technology piece. We have filters and other advanced functionalities that make sure that finding the information is easy, and that finding the information when they need it in the format that they need it is very convenient as well. And after finding information, so this is something very important that Dr. Farina mentioned during the conversation, it's not only about finding the information, but you need to share it, right? If you don't share it, there's not much use to the information. So sharing with your colleagues and ensuring that everyone in the organization also has the means to share and to search for the information that they need. So that everything that I've just mentioned here is available in the Clinical Key Suite. And what I described is really just the tip of the iceberg. So if you want to know more, and if you want to have a demo at your hospital and try it out, you can also try it out. You can send us an email, and I'm happy to show you around as well. Now, another tool that I wanted to share, and this is where the presentation gets really cool. That's the feedback that we always get when we show this. This is called Complete Anatomy, and it's a fantastic example of how technology can be used also to share knowledge. This is an education platform that allows users to investigate in detail human anatomy. So as you can see here, I'm going to play this video again. You can investigate anatomy in 3D. So this is really transforming medical learning and practice around the world, as you can see here. Not only for the medical students, of course, which is what we mentioned right at the beginning. How can we make sure that medical students are equipped with everything they need to be able to practice safer? But also for professionals. They can use, for example, in practice to educate patients. And I will give you a personal example. I am going to go through a knee surgery in the next couple of months. And I have been on Complete Anatomy for many hours now to understand exactly which structures they are going to move, to operate on. And that was actually part of the discussion that I had with the orthopedic surgeon. He said, well, let me show you what I'm going to do with your knee. So that was, now speaking from a patient perspective, that was a big relief, understanding, and really, it was easier to understand. It was easier to learn and to see what was going to happen. So that is just one of the uses. Now, imagine as a clinician, if you have a 3D model that you can use for anything that you want, basically. That is what this solution offers. So we have not only the staff education part, of course, the medical students and all that, but we also have the component of patient safety, patient participation perspective. And that's just a quick example. Now, still on the visuals, I want to give you another example of how technology can support decision-making and also patient safety because of that, which is Techyx. So when providing care to patients, we know that clinical decision support can be a clinician's best friend, right? And what you see on your screen right now is Techyx. and it offers more than 4,600 diagnoses that are written by the leading experts in radiology. It includes 20,000 images and the possibility to compare images. So what you see on your screen right now, and Dr. Farina, I chose this example for you. This is a Takotsubo cardiomyopathy, so I'm very sure that you're very familiar with it.
I was panicking. I was not sure what that was.
The Takotsubo cardiomyopathy. And so what is very interesting about this is that not only you can see the image, you can read about the key facts, the terminology, the diagnosis, but you can also compare it with differential diagnosis. You can read patient cases, and there are also tools like cancer staging tables. So Techyx is a very robust visual platform that is used for radiologists, for example. And we have a sister platform used also for pathology. And the last example that I want to share with you today, before the very short Q&A session that we can have, is an order set. So order set, as you see, is a set of orders that can be easily integrated into the EHR. And what I find very interesting about order sets is that they create the bridge between the theory and practice, which is what we mentioned when I said the 42 years that it takes to be updated, right? So that's what order sets do. They keep you updated by including the most recent evidence in your existing workflow and nudging you to make the safer decision, because you can read the evidence-based guidance that compose the order sets. So instead of having to go to your database, for example, and one of the conversations that we had, Dr. Farina, right before, on the preparation sessions, was the size of the guidelines. Sometimes guidelines can be 75, 100 pages long. How do you make sure that everyone is always reading the most current guideline and that they have everything in their thoughts? Do you think this is a challenge? Does that pose a challenge?
Our vaccination guidelines are about 170 pages, and we were up to the 4th edition. And obviously, I read them, and the point of reference was just people giving me a call.
Exactly. So you do need someone that will do everything, and then people will give you a call. If you were not available, and were you available for 100 calls at the same time?
No, of course not.
I would say no. So that's the purpose, right, of order sets as well. And of course, if you want to have a deeper dive into order sets or any of the other solutions that we saw today, so we saw different buckets of solutions, right? We saw those solutions that are reference solutions. So when you need to search for something, for example, there's a patient that comes and there's a suggestion of Takotsubo cardiomyopathy, I can go into Techyx and find the imaging exams, compare those images, and I can also read some patient cases, for example. If I want to dive deeper into Takotsubo cardiomyopathy, I can search on clinical key, for example, and when I'm sharing with my patient, I can also use complete anatomy to show. So these are just quick examples. I just made up that story of a patient coming in with Takotsubo cardiomyopathy. But if you want to know more about these solutions, I will be happy to do a proper walkthrough the solutions. Of course, I can present each solution in 1 hour or more and give you access as well, so you can play around. And we would be keen to just understand how technology can further support your initiatives, of course, and support you overcoming the challenges and also the opportunities that show up in terms of patient safety. We now have a couple of minutes for questions. I see there are comments here coming up. Let me just go back to the Q&A. Another comment about the information sharing. I'm handling the quality department at one private healthcare company, and normally I will share those data through quarterly and monthly clinical committee meetings. the challenging part is also the need for constant cooperation and involvement in quality improvement activities among the clinicians as well. So Dr. Farina, how do you make sure that the clinicians are still involved, that they keep being involved in the quality improvement activities?
All right, so I think I have to, number one, thank our management, because we actually have two doctors in the quality management department to bridge between the quality department and the clinicians. And I do have a very efficient quality management team in IGN. And the issue was actually bridging that, someone from quality has to speak to clinicians, and mind you, I have cardiologists, cardiothoracic surgeons, anesthetists, they are key opinion leaders, and they're very good in their clinical work. And it can be intimidating. And so, number one, you have to understand that a clinician is a clinician first, and that their time is limited and time is precious. So in engaging them, you need to summarize, and you need to stick to time, make it short, sweet, and impactful. And at the beginning of any engagement, you need to have an agenda and what you're trying to reach, what decision you're trying to reach, so that it just abbreviates anything. It abbreviates that whole encounter and gives them a pleasant encounter with the quality department, rather than you keeping them for hours and hours and trying to, trying to engage them with a lot of data that has not been analyzed or has not been summarized. And let me tell you this is where the clinicians can give you the best input, is when you have summarized and really thought about that engagement that you're about to have with them, and be brief and be meaningful. And you will get this support from the clinicians slowly. And remember that principle of what's in it for them. I think these are the few things that I think are important. And I'm speaking as a clinician myself. Sometimes I have to divide my time between the two, and because I wear two hats, but I know that I'm a clinician first and my patient comes first. And so, timing, who are the right people that you're going to meet to make an engagement effective, who are the correct people to be in that situation, and come to them with good data, and come to them with proposed solutions, and this will really help in reducing their burden with their involvement in this part of the health and clinical care of patients. I think that would be my advice. But that was really good feedback from this person handling this private health, Muhammad Zarif, yeah? So I hope that little advice would help you along the way.
Thank you. Thank you so much, Dr. Farina. That was exactly the purpose of this whole conversation, right? Was to make sure that we could have a conversation with the audience and also learn from each other, and to make sure that we are sharing valuable content and ways that they can use to improve, to enhance the quality improvement actions that they have in their hospitals nowadays. We are unfortunately out of time. We're at time. So I would like once again to thank you very much, Dr. Farina, for your generosity, for sharing your advice, your suggestions, your experience. It was very, very, very pleasant to share screens with you today. And I hope you also had a good time. I just want to make one comment very quick. I see on the chat many people asking about complimentary access to the solutions. You can scan the QR code that you see on your screen, and you can just fill out the feedback, and we will get in touch with you. So again, Dr. Farina, thank you so much. Thank you.
And very engaging with the audience. I love that.
Thank you so much. And if you would like to continue this conversation, you can send us an email, and maybe we can do another webinar, another forum, another session where we have more time for discussions as well. Thank you so much. And I hope everyone has a good day, a good evening. And thank you so much again, Dr. Farina, for sharing your knowledge with us today.